think so with this, today after hearing about diseases, infections, vaccinations, pandemic, a lot of other profile, we come to an important part where, as the topic said, maybe a magic pill, maybe for CardioRenal Metabolic Syndrome. I would go one step further and say diabetes CardioRenal Metabolic Syndrome. So what the plan for this panel discussion would be that I am one first speaker, Dr. Joshi will be the next one, Dr. Kerkar, who is a cardiologist, renowned cardiologist, is in the audience with us. He will be the third speaker. Dr. Tevaskar would come in at the end. Then we have a small discussion towards the end. Each of one of us will hardly speak for 10 to 15 minutes. We discuss out, I will moderate the discussion. And at that point in time, if anybody has any questions on this topic, there's mics in the aisles near the front and at the back. You can come, you can ask us questions at that point in time. So this is what we do. We talk about DAPA as a molecule. We try to elucidate as much as possible on the molecule, giving in-depth analysis, interpretation, trial results, safety profile. So as clinicians, all of us can take home some message and start using this molecule with utmost confidence. This is me just doing TWTs, time wasting tactics, take my slide uploads. This was what my professor used to say, ki when a student didn't know the answer, he used to keep on just giving blah blah blah, so I'm doing this blah blah blah, but it's still loading. I hope it's going on well.
Yes.
All happy with the session so far? I take the opportunity of thanking this robust audience. Sunday morning, kaun aata yaar? I mean, I'm really happy. You found the program interesting. I am so happy all of you have come. And we promise you the department will keep on with the blessings of the Indian College of Physicians. The Secretary, Dr. Tevaskar, is here. The future Secretary, Agam Vora, is here. The Dean of ICP, Professor Deshpande, is here. With their blessings, we keep on having such more programs in the future. And I hope we see such robust attendance in the future as well. Okay.
This strategy has any name? First slide is projected for a long time and you can read everything.
It's called marketing, sir. Single word. Right, so without any further ado, I think we jump into the topic. That's what I have in hand today, DAPA. It is a talk by our supporters, the AstraZeneca, who's been most magnanimous in supporting the entire event. We shall be talking about the glycemic events and extending the benefits to prevent a cardiorenal outcome. So during my talk, in the first 3 slides, what I'll be trying to cover is 1, that dapagliflozin definitely has a significant reduction in the sugars. 2, it definitely reduces the body weight. And number 3, while glucose control is fundamental in a diabetic management, we also have to understand that it may not reduce the risk of all heart failure events. We still have to go a step further and see what more we can do towards the diabetic patients who are at a prone risk for both heart and a diabetic nephropathy. So just controlling sugars, as D. Franzo rightly said, there's the omnious octet first and the dirty dozen came in. That today when all of us as clinicians sitting in this room see a diabetic patient in our OPD, it's not only about sugar control. We need to look at the kidneys, look at the heart, overall as a patient. So how do we do that? First, as always, the statistical incidence of the burden, cardiorenal disease in a type 2. So this is from 2017, heart failure global prevalence 64 million. Chronic kidney disease, global prevalence 2017, 843 million. Put it together. Diabetic prevalence 2019, 463 million. So it's a ever increasing non-infectious epidemic or rather a pandemic. Heart failure and CKD is a vicious circle. One causes the other and one can worsen the other. 24% of these patients with type 2s have heart failure as their first complication. And 58% of patients with type 2s will eventually develop a chronic kidney disease. So we have to clinicians try to reverse these percentages. We can't accept it. If so many of our patients are going to land up in millions, 24%, in millions, 58% is not a small figure. So how do we do that? Let's look at the prevention of cardiorenal outcomes and the prevention of kidney disease. So there are certain good trials. DECLARE is one of the most prominent robust study which came and enrolled patients early in the disease continuum, including those with the atherosclerotic cardiovascular disease, ASCVD, with predominantly a preserved renal function, and they included patients with type 2 with either a multiple or a more than 40-year-old with an established CV risk. The patients with DECLARE trial had a better renal function than an empiric outcome or a canvas trial. So EGFR mean of an ml per minute per 1.73 square meters, DECLARE had 85.2 and microalbumin percent in DECLARE was 30.9, much better compared to the CANVAS and the EMPIRIC trials. DECLARE also showed that DAPA slowed renal disease progression. So if you have a patient today with a sugar A1C of 7.8, kidney creatinine of 1.9, he is a borderline CKD and you want to delay his progression to a full-blown renal failure. That has exactly what this trial has shown, that people with type 2 with a predominantly preserved renal function to begin with, it will slow down the progression of that kidney disease. Favorable outcome thereby on albuminuria, cut across basal, the urine albumin creatinine ratio categories in patients with including a normal albumin excretion. What about heart failure? It overall prevents hospitalization. Dr. Kevkar is here, I am sure he will elucidate a little bit more upon that aspect, but DAPA has shown a reduced risk of heart failure hospitalization in patients with type 2 and a multiple cardiovascular risk factors or with an established heart cardiovascular disease. So you imagine that patient who undergone angioplasty some years before, he's come to you today for sugar controls, he has an established cardiovascular disease in them as well. The risk of heart failure associated hospitalization as shown by these pie diagrams and graphs are much better. Dapagliflozin has a well-established safety profile in patients with type 2 CKD and a reduced ejection fraction heart failure. These are the charts towards it. So at a 10 milligram dose of DAPA in a DECLARE DME trial compared to placebo, look at the amount of people they tested. It's 8,500 plus. So a robust trial, volume depletion, renal adverse effect, fracture, amputation, major risk of hypos, diabetic ketoacidosis, genital infection, UTIs and Fronius gangrene risks were all much lesser compared to the placebo group. DAPA CKD subset, again the left hand side 10 milligrams of DAPA achieved a much better control and to these complications compared to the placebo group, and DAPA heart failure group also showed a beneficial effect. So overall major hypo and diabetic ketoacidosis was not observed in patients with type 2 who were on a DAPA CKD or a DAPA heart failure subgroup. What do the guidelines say? We have certain guidelines which we follow, the ADA, the ESC. Let's see what do they say. The standards of care in the American Heart Diabetic Association in the year 2022, they have put forth that primarily anybody with the ASCVD indicators of high risk, you can start with the SGLT2 with a proven CV benefit. Those with a heart failure, again you can start SGLT2 inhibition. So I've just taken a zoom in, zoom out rather of the chart in the background. And those with CKD, again with albuminuria, you can start. Those without albuminuria also you can preferentially start SGLT2 inhibition. So overall SGLT2 inhibition has been recommended independent of glycemic control in patients of CKD, heart failure, high CV risk, apart from established ASCVD. So in simple words, this is a molecule which today even a cardiologist will use. There's Professor Vaidya here, Professor Kerkar here, senior cardiologist from the community. I'm sure they will agree that in a non-diabetic patient also the use of such molecule has come forth without the risk of a hypoglycemic episode. So you don't need to be a diabetic to be put on this molecule. The sugar usage are different and a cardiovascular usage is different. ADA guidelines, evidence with the different SGLT2 inhibitors. Primarily the molecule at hand we are discussing this afternoon, DAPA has shown a primary heart failure outcome data which is successful, primary renal outcome data which is successful, and a reduced heart failure CKD progression in CVOT which is successful in DAPA as compared to its peers, not so much in CANA, not so much in EMPA. The ACE and ACE 2020 algorithm for glycemic management again has put that lifestyle modification, ongoing glucose monitoring, the CGMS is much required. After that, independent of the glycemic control, if there is an established or a high risk of ASCVD or a CKD, it's recommended that you put the patient on SGLT2 or a GLP-1 receptor agonist. Monotherapy, dual therapy, as per the entry A1C. So if entry A1C is less than 7.5, maybe a monodrug, no confusion there. Metformin always has been ruling the roost. If it's more than 7.5 to 9 A1C, I think dual therapy is the norm, and then beyond 9, then triple therapy. And most of the drugs, if you see the lower charts at the bottom, the list of the lower drugs at the bottom, most of them will have an SGLT2 somewhere right as a second or third line after metformin in these subgroups. This is Primary Care Diabetes Europe. It did a position statement on the pharmacological management of type 2 diabetes in primary care, a very nice study. They had a risk stratification. We had a very high CV risk subgroup and high risk CV group in the remaining diabetic patients. The recommendation, so what does A mean? A means the guideline, E means the expert opinion. So this was a trial which not only used the guidelines from the trial, which also had some experts, some diabetologists, some cardiologists in their group, and they used their opinions as well. So left hand side the first line opinion, right hand side the second line opinion. So ASCVD established, the trial say metformin. What did the experts say? Also consider SGLT2 inhibition or a GLP receptor agonist along with the metformin. Heart failure, the guidelines say metformin, the experts say again SGLT2 alongside this thing rather than a stepwise. So stepwise means not after the other. In simple words, aaj sugar ke liye aaya, HbA1c 7.9, you start on metformin, next time देखेंगे add on करने का ना. These guidelines are saying today you start with a combination. Don't wait for a next time because you want to control sugars and thereby the complications today, not the next time. CKD, metformin is by the guidelines. Experts say again SGLT2 can be considered alongside. High CV risk, again metformin by the guideline, and the SGLT2 or a GLP-1 receptor agonist as per the expert opinion. Right hand side, similarly, right at the beginning, SGLT2s have been asked to be introduced in the various subset of these clinical scenarios. My last slide, I'll be ending here. This is the European guidelines for ESC and EASD in 2019. The treatment algorithms in patients with type 2 ASCVD or a very high risk have been shown that type 2 with who are drug naive can also be put on SGLT2 inhibitors or a GLP receptor agonist monotherapy. A very bold statement. They have gone in one step further and said that maybe even before metformin you can try it out. Metformin monotherapy becomes the other part of it. Type 2s on metformin with a ASCVD or a very high risk or severe risk can be add-on to SGLT2 inhibition, or we can continue metformin monotherapy. So with that I stop my talk. I believe what we shall do, as I said in the beginning, thank you so much, is that we shall take all the other speakers in a row and then at the end a few question answers and discussion can be done in. So I would request the chairperson to please call upon the next speaker.
Thank you, Amit. It was a nice talk. Again, second, we have Dr. Shashank Joshi. He doesn't need any introduction. Again, it will be a virtual. He'll talk on intensification of therapy with DPP, and SGLT2 inhibitors.
There is a conflict and duality of interest of this talk with the AZ folks who have been kind enough to provide these slides approved by their medicine. So we know that SGLT2 inhibitors and the DPP4 inhibitors, like a combination, can be combined effectively and efficiently. We know that when we combine an SGLT2 inhibitor like DAPA and a DPP4 inhibitor like SAXA, 6 out of 8 mechanisms which are given with metformin are very efficiently covered. And if you see the octet, very clearly we can see that the gliptin works on the incretin effect. It works on the beta and alpha cells. Metformin switches off the hepatic glucose output, and SGLT2 inhibitors naturally work on the glucose absorption. So, and metformin also works on the glucose uptake. So this combination of DAPA-SAXA or a gliptin with SGLT2 addresses multiple concerns of glycemic control, but predominantly also look at the cardiorenal risk reduction, which is primum non nocere. First of all, do no harm, but if at all, be of some value or use in our diabetic population. Let us look at specifically the SAXA-DAPA dual combination with metformin across all A1Cs. If the A1C is above 9%, if the A1C is between 8 to 9%, or if the A1C is below 8%, you can see in this graphic by Julio Rothenstock, consistent data submitted to the US FDA shows that the SAXA-DAPA combination is effective in lowering the A1C. Higher is the A1C, better is the drop in the A1C, which has been documented from 1.87, 0.84 and 0.45. Also, when we look at glycemic control, this glycemic control, when we have DAPA-SAXA and MET, is comparable to a insulin when combined efficiently and effectively, minus the hypoglycemia risk and minus the weight gain risk, as illustrated in this diagram, which was presented by Isboli et al. At the Orlando 2018 ADA. We also have very good data to suggest that a DPP-4 inhibitor, and it's very old data, to suggest almost 6 years back or 7 years back that a gliptin like saxagliptin reverses microalbuminuria to normalcy in more than 1/3 of the population. And if you use a FDC of DAPA-SAXA, the safety profile is comparable to either of the components alone with minimalistic or minuscule risk of hypoglycemia. So there is a 50% reduction in the genital infections and volume depletion in this combination rather than using a dapagliflozin. So if you look at the beneficial effects, the low risk of hypoglycemia is seen with both the agents, DPP-4 and SGLT2. The weight neutrality and weight loss is classic for gliptins and SGLT2 respectively. The cardiovascular safety is reasonably overwhelming both for DPP-4 as well as SGLT2 from a safety standpoint. From a protection standpoint, clearly it is there with SGLT2, and the systolic blood pressure is reduced by SGLT2 and is neutral for DPP-4. Finally, there has always been a concern of heart failure in saxagliptin because it was the early study of saxagliptin in its first trial, which was published long time back, on the SAVOR-TIMI 53. And the hazard ratio of heart failure, hospitalizations, you can see when they are exposed to these patients on the medications, have further reduced, even if the trial did not end in time. So that hazard ratio which was seen, which was 1.27, which clearly has been documented in this graphic in an illustrated way. So when we look at the SAVOR-TIMI trial in deep dive, and Skiria et al. In circulation almost 8 years back looked at rehospitalizations after initial hospitalization for heart failure was similar between both groups. There was no difference in weight overall for those with history of congestive heart failure. There was no clinically detectable fluid overload. There was no difference in the troponin T or CRP between groups. Medication of saxagliptin continued in all patients, and hospitalization of heart failure issue was caused by 61 patients in the saxa arm. Could be due to many of the things, but of course pharmacovigilance has been recommended for the same. There is also consistent data of a Korean randomized real-world study in various other agents of the lower risk of cardiovascular disease, particularly in the sitagliptin cohorts. So clearly you can see that when the overall meta-analysis of various gliptins were done in Korea, the hazard ratios were pretty similar, and presumably that it is cardiovascular safe. So probably there was a smoke. We don't know whether the smoke translated into signal, but after 8 years overall, we know that probably it was more of a smoke and less of a signal. But we need vigilance and caution. So basically we know from these results of SAVOR-TIMI 53 study, the risk of hospitalization for heart failure, we don't know was related to patient selection or others. Nevertheless, there was a major heart failure study which dedicated saxagliptin versus placebo when added to standard of care on the left ventricular end diastole. And they did an MRI, magnetic resonance imaging, and other imaging with biomarkers for heart failure and type 2 diabetes. And the sitagliptin, when added to standard of care, was not associated with increased risk of hospitalization of heart failure. Mind you, this study was of sitagliptin and not of saxagliptin. So this was the major heart failure study where saxagliptin, sitagliptin and placebo were concerned. This was a dedicated study to look at this particular entity itself. It was sponsored by ASI. It was a randomized double-blind placebo-controlled study. 13.8% of patients were from Asia Pacific, 48% were from Eastern Europe, 25% were from Central Europe, a very small minuscule percentage of 2.9% were from North America and 9.5% from South Africa. And in that data, clearly versus the placebo, the left ventricular end diastolic volume was low compared to the placebo. That means saxagliptin appeared to be reasonably safe. When a comparative analysis for hospitalization for heart failure was made saxagliptin, sitagliptin and placebo. All three were almost similar. So this dedicated study which looked at this question, called major heart failure study, looked at saxagliptin plus standard of care, was not inferior to placebo and did not document any significant change on the left ventricular end diastolics and systolic volume. Neither did it have any impact on EF or ejection fraction, left ventricular mass, NT-proBNP from baseline. The effect of saxagliptin on cardiac structural changes compared to placebo plus standard of care was similar. So in the major heart failure trial, which was sponsored by ASI, the manufacturer of the combination, did not document or demonstrate any cardiac structural or biomarker changes indicative of worsening of heart failure with type 2 diabetes with established symptomatic heart failure. So remember, in established symptomatic heart failure. So obviously what I try to summarize is clearly SGLT2 inhibitors have a beneficial role beyond glucose control, and we have DAPA CKD, DAPA heart failure documenting the same. The DECLARE study clearly shows the primary composite outcome when combined with hospitalization of heart failure and cardiovascular death was significantly reduced with DAPA-SAXA and reduces the onset and progression of renal dysfunction in kidney disease. And therefore, if you use the combination, it is very effective on glycemic control and safety profile, and probably has a lower risk of hypertension. So it's an efficient combination in treatment intensification. And I looked at very closely the pharmacovigilance and safety issues which were originally considered as a part of the SAXA table, which appeared to have been resolved under a tight vigilance of randomized control trials. Thank you for your patience.
Both the previous speakers have spoken about dapagliflozin and diabetes, and I've been always told that बुजुर्गों ने कहा है, never stand for too long between a hungry audience and their khana. That is what it is. But you heard from both the previous speakers that this magic pill does not cause hypoglycemia. It's also when you are, especially I'm going to be using it in heart failure patients and that too in non-diabetic patients. So that is what this is all about. And just to go down the lane in terms of some timelines, because since I was so impressed hearing Dr. Mangesh Tivaskar's talks about timelines wise, a beautiful article, a beautiful editorial on DAPA-declared TIMI, people talked about DAPA-declared TIMI, about the serendipity of SGLT2 inhibitors. It is a US FDA mandate that any drug introduced for lowering blood sugar by the diabetologist ought not to cause some other side effects, and therefore especially cardiovascular side effects. It all started after the fiasco of rosiglitazone, as you are all aware of, that it caused actually increased myocardial infarctions and mortality. So in that business, the serendipity of all these three SGLT2 inhibitors in DECLARE TIMI, EMPA-REG and the other CANVAS program, what they found out is that these molecules reduced heart failure hospitalization when actually they were given to diabetics and followed up for over 4 years or so to lower blood sugar, and they were cardioprotective. So as a cardiologist, I stand here to tell you that I would very much like to own this molecule as a cardiac molecule. It, by the way, also lowers sugar. That is how it is. And of course, Dr. Mangesh Tivaskar will then come and tell you that it has got that renal benefit as well. So with that introduction, let's get on with the business of so heart failure. A little bit about heart failure. We all know is an insidious disease that starts well before the first symptoms of heart failure. And when a patient is symptomatic, we call them as being in stage C. Well before that, you have the stage A and the stage B, which are extremely important to prevent heart failure, in the sense that in stage A, you are at high risk to develop heart failure by virtue of your coronary risk factors. Usual ones, diabetes being the leading one, hypertension and what have you, the other coronary risk factors. As also, if you've had COVID, then also you could be stage stage A to develop some myocarditis and subsequently develop heart failure. That's what we are talking about in stage A. Then you have the stage B, wherein already some structural change has occurred. Mind you, patient is not yet symptomatic. Structural change shown there, you might have had an ACS, the patient might have had an ACS, and that would have caused a low ejection fraction. Or for that matter, patient is a long-standing hypertensive, has caused LVH, and he's also a diabetic, and without coronary artery disease, yet he becomes a candidate to develop heart failure, but not yet symptomatic. So the funda of these two stages is to prevent heart failure. Once you are in the stage C, as you can see, you start getting a rapidly progressive course, punctuated by all those dips that are shown. Those dips are heart failure hospitalization events or acute exacerbation, or the need to intensify your diuretic therapy, which means unless we intervene here by way of good guideline directed medical therapies that we're going to discuss, you will cause the patient to go downhill into a refractory phase. So funda is that try and prevent and recognize heart failure early. But in this huge database from the US, where healthcare setting, where they looked at the first new onset of heart failure diagnosis, it is often missed in an outpatient setting, and 40% of the time, nearly 38% of the times, patient, and more so in women, it's missed. Patients first present when they are in an acute stage, and I showed you the graph. Once an acute stage, you're going to go rapidly downhill. Can we diagnose this early? That is the basic thing, and by that we mean that the World Heart Federation has come up with a roadmap, a pathway to identify opportunities for a timely heart failure diagnosis. Heart failure per se has got non-specific symptoms by themselves. You know what, these patients are non-specific symptoms. Very often they land up going to, I heard Agamvora, they land up going there as a COPD. Or for that matter as a COVID pneumonia. We saw this during the last 2 years during the pandemic. So this loops of misdiagnosis, in that the patient present late, he goes to other people like the primary care physician, the endos because of his diabetes, or the nephros and the pulmonologist, but delay to come to a cardiologist. And that delayed referral means what? That you have gone into the worsening stage and you have gone downhill. We need to catch these blokes early. And towards that, one basic funda message you must remember: an elderly hypertensive has come to you. He's a long-standing diabetic also and complains of ankle edema. There is another cause for that ankle edema besides the amlodipine that he is taking. That's a missed opportunity of diagnosing heart failure very often. That's what we see. So what are the potential ways to reduce the delay in heart failure diagnosis? Improve patient awareness and education, enhance the knowledge of not only the patients but also about the physicians, about the diagnostic criteria and the clinical practice guidelines, and increase collaboration amongst all providers, which is exactly what this session is all about. We have the other providers also here. So this is, and there is again always a defeatist attitude on the part of even the cardiologists, that very dismal prognosis, hardly anything to offer to this patient. No, current times are exciting times in heart failure management, not only because of the first serendipitous molecule that the gentleman by the name John McMurray gave. I had the chance to collaborate with him because I am a principal investigator for this trial, and after that for the Paradise MI I am the national coordinator. ARNI was a blockbuster molecule that we know, but 5 years after ARNI, the same gentleman gives you DAPA-HF trial with this magic pill. First and the largest SGLT2 inhibitor HFrEF trial that successfully improved outcomes and symptoms. To give you a brief overview, 4,700 plus patients, half of them were non-diabetics. In diabetics, we know that the previous CVOT showed you that they prevent heart failure. Why not get the non-diabetics? And they were randomized to DAPA and placebo. And placebo means not that the patients were not getting the standard of care. They were more than 90% of these patients in the entire population were on standard of care, which means 90% of them already on beta blockers, or 95% of them on some kind of a RAS blockade, 70%, very huge numbers on MRAs. which are the standard of care at that time, right? And with usual inclusion criteria, the eGFR cutoff you can see is 30 ml per minute. And what did they find? A significant reduction in the primary composite outcome of CV, death and worsening heart failure. A 26% relative risk reduction on top of standard of care, good guideline directed medical therapy. So add on to the care and the number needed to treat just about 21. And what do you see? CV, death and both the outcomes, not just driven by heart failure hospitalization. Even cardiovascular death is reduced by an 18%. And heart failure hospitalization by 30%. And this beneficial benefit was consistent in a broad range of patient population, regardless of whether the patient was a diabetic or not a diabetic, was on ARNI or not on ARNI, was on background diuretic, whatever dose it be. And of course the baseline LVEF or the NT-proBNP levels, whatever, did not matter. And as if your eGFR were more than 30, less than 60 versus more than 60, it did not matter again. So the eGFR did not matter again. Of course, you have to be more than 30 there. And surprise of surprise, there was a reduction also in the secondary outcome, the all-cause mortality. We want to live long, right, with heart failure. Not only CV death, but all-cause mortality, as a surprise and wonderful finding, was reduced. And importantly, not only that was reduced, but symptoms and quality of care. All these elderly heart failure patients are talking about improve my quality of life. What's the point of that extra 18 months that I'm going to live at my age? So, and again, as the previous speakers have alluded to, safe and well tolerated. And 28 days, Mangesh Tivaskar talked about 28 days somewhere it took for Banting to get his first patient. But remember this 28 days here. As early as 28 days, if you focus on the hazard ratio plot out here, and if you look at the plot of the hazard ratio, where you see at 28 days, where the upper bound of the confidence interval crosses the line of unity, everything less than this is significantly better. So as early as within 28 days, you are going to reduce the risk of a death and reduce the risk of hospitalization for these patients. Hence, start early. Not only that, we know heart failure patients are prone to getting sudden deaths. And in this trial, a post-hoc analysis, which is hypothesis generating, a composite of ventricular arrhythmia, resuscitated cardiac arrest or sudden death was reduced by 21% relative risk reduction. Not only that, there were non-diabetics. About 2/3 of these non-diabetics were actually in a pre-diabetic range, but their new onset diabetes along the course of the trial was reduced by 22%. Of course, you will say that's not something great, right? It was after all supposed to be an anti-diabetic molecule. And across, you compare in the maroon bar, they are showing diabetics and the non-diabetics. Whether in diabetics or in non-diabetics, it was safe and well tolerated. The adverse events of interest, when you are giving a glycosuric drug, which is also going to be a diuretic, you are worried about volume depletion. The adverse events of interest, volume depletion, kidney acute injury, or fractures, amputations, which were seen with other CVOTs with canagliflozin especially, were not significantly different between the two groups. There is a lot of hue and cry because they are glycosuric, you will end up getting urinary tract infection, but not borne by this trial, at least a huge trial of 5,000 odd patients. You see the UTIs as serious events or UTIs leading to discontinuation of the drugs absolutely similar whether you give a placebo to the patient or you give dapagliflozin. So not a matter of concern really, though urologists have papers where they talk about urinary tract infections, okay? But here we come again. If at all there is a numerical increase in mycotic genital infection, so what you need to tell your patients is to maintain personal hygiene, and that those genital infections again did not lead to discontinuation of drugs and can be well managed. The three most important ones, and Fournier's gangrene had a black box warning, red flag thing. And all these three, hypoglycemia, diabetic ketoacidosis, mind you, it is contraindicated as of now in type 1 diabetes because of the risk of diabetic ketoacidosis. All these, if at all, occurred in the diabetic patient group, not in the non-diabetics, and numerically so fewer patients. So fairly safe molecule. Again, after that, a year later, at the same congress in ESC, empagliflozin was presented in the Emperor reduced trial, much less number of patients as compared to this, but sicker patients, NT-proBNP values were higher, 50% of the population again non-diabetics, and identical hazard ratios that you see 0.75. But the CV death, although numerically lower 8%, did not reach statistical significance, so also the all-cause mortality did not reach statistical significance. So how do you implement dapagliflozin in practice? Of course, today, based on these trials, SGLT2 inhibitors and dapagliflozin has become the fourth foundational pillar of, why are they foundational pillars? They are all survival enhancing treatment. 4 pills, not just 1 pill. We're talking about 4 pills here. And this is endorsed both by the American College of Cardiology experts as well as by the ESC guidelines, which were released about 6 months earlier to now. So having said that, there is a modern day mantra is what, therefore, when you treat a heart failure patient, you don't go the conventional way, start one molecule, worried about hypertension, then start other. It will take you 6 months. By that time, the patient may not be there. So give a little bit of everything. Ensure that within 4 weeks, all 4 drugs are on board. Just last couple of minutes. So what would happen here is that this proposed new paradigm to treatment is giving 4 drugs in 4 weeks, early rapid initiation. There is a funda behind that. Remember that 28 days again. So as early as within 1 month, not only with dapagliflozin but with other molecules also, you start getting benefit early, the curve starting to diverge early. So, but as a step 1 here, you may want to use the safest of all. You definitely want to use SGLT2 inhibitor in addition to beta blocker. Arguably, beta blockers are the one that reduce the risk of sudden cardiac death the maximum. So you want a beta blocker on board and you want an SGLT2 inhibitor because of the early benefit of hospitalization and short-term worsening of heart failure, which might happen rarely with beta blockers, is well compensated by this. Again, the ESC position paper from European Society of Cardiology, they identified 11 different type profiles. And what did they find within this? Based on their blood pressure, the phenotypes, blood pressure, heart rate, presence of AF, CKD or hyperkalemia or hypertension. All these profiles, across all these 11 profiles, you see SGLT2 inhibitors, dapagliflozin, highlighted in yellow, scores over all the others. So, final slide, this is what you can expect. When you give these 4 drugs over a 2-year period, if you were not giving anything, your mortality at 2 years would be 35%. It will get down to absolute risk reduction of 25% to 10%. The relative risk reduction, the quadruple, the 4th pillar, if you add, will bring it down to 73%, which is big. So don't even think that heart failure is a disease with bad prognosis as such. And NNT, just 4. 4 patients you treat like that, you mind it. Again, you need not be at target doses with the other drugs, other 3 molecules. That's what again the American consensus document says, that you need not be, get my mouse, target doses with the other drugs before instituting them. And I've already alluded to the mycotic genital infection and that it has very little effect on the blood pressure. So what is an ideal magic pill? I'll just go over this last slide. 1 pill, 1 per day with no dose titration. Just remember 10 milligram. Diabetologists might be used to going to 25 milligram with this molecule. Just 10 milligram dose substantially improves survival and prevents hospitalization, meaningfully improves quality of life and functional status. Benefits appear rapidly within days to a few weeks of initiation, exceptionally well tolerated and safe, does not lower blood pressure, and if at all does so very minimally, no adverse renal effects about which Dr. Mangesh Tivekar will talk about, and instead it actually preserves kidney function and prevents dialysis. affordability and accessibility, you talk to the company out there about the affordability and accessibility, and that is where dapagliflozin fits the bill. Thank you so much.
Can you load my slide, please? Yeah, the fourth one. Yeah, okay, fair enough. Right, so here we go. So beautifully, as Kerkar sir has lovely, put in the perspective of cardiologist. Shashank has already spoken about the endocrinologist perspective. Amit has beautifully set the ball rolling. I have a disclosure for this talk, that please understand that I am not a nephrologist, even though they have made me a nephrologist today. But I am not a nephrologist, so all difficult questions to Shashank, who is going to be here, and also Kerkar sir. So, my job is very simple. So what I probably look at dapagliflozin or as an SGLT as a group of the drug. My take. This is probably, sir, is the only molecule where physicians, cardiologists, diabetologists, nephrologists have actually come to the stage and the platforms and agreed on everything. Otherwise, we have all enjoyed tug of war between all these specialties, right? But this is one molecule which has united all these specialties. Now, the job is, whether it is a diabetologist drug or a nephrologist drug or a cardiologist drug, that probably needs to be sorted out. But whatever it is, this is a new, I would say, revolution happened in the management of diabetes. And same thing as sir was talking about cardiologists and how aggressive and proactive we need to be whenever you are managing the target organ related to diabetes. I have got a very, very strong suggestion to you that whenever you are managing your kidney possible high risk patient, as you talk about high risk atherosclerotic cardiovascular possibilities, same way these are the patients who are at the very high risk of developing kidney disease. And unfortunately, even in India in today, we know how few nephrologists are there. And look at the burden. And the misery is that still around 50% of CKD is not diagnosed. 50% of the patients are not even aware that they have a kidney disease. That is the point where I want to bring your attention. Now we know about the importance of managing the atherosclerotic cardiovascular disease very well. But look at this. This is a beautiful. As the patient progresses from stage 2 nephropathy onwards, it's not just the cardiovascular disease, but it is which is only atherosclerotic event, but there are non-atherosclerotic challenges which also have an equal, or I would say even a larger share of mortality and morbidity. Now why I say so that, because you have seen nephrologists in their conferences talking about that when somebody reaches end-stage renal disease, 50% of the crowd, those who have got established kidney disease, do not even reach the end-stage renal disease. Before only we lose them because they have developed some cardiovascular event. Now that is the brutal reality. So look at LV arrhythmias, look at atrial fibrillation, look at sudden cardiac death, look at the hemorrhagic strokes or the various vascular events, including valve calcification. The load is almost similar. And heart failure, it's an established phenomenon. I don't have to talk anything about it. Whether it is a diastolic heart failure, systolic heart failure, systolo-diastolic heart failure because of some other reason. But what is the beauty of these drugs, and especially dapagliflozin, is this, that I can confidently say that now we are for the first time being the doctors. I still remember Kerkar sir teaching us, and he taught us about systolic heart failure. We never thought that there can be something like heart failure with the preserved ejection fraction. Whenever we talked about heart failure, we knew that we are talking about the ejection fraction which is less than probably 40. Now they have taught that even though the left ventricular ejection fraction is 60 and above, still the patient can have heart failure, and that is what we exactly know as the diastolic heart failure, which has got even higher mortality. And we never had any drugs. Unfortunately, till the invent of SGLT2 inhibitors, we never had any drugs. And same way, EGFR, which we took as a standard of monitoring, is not the only way to monitor your kidney disease patients. In fact, I will tell you that if you look at the DAPA-CKD trial, or the declared TIMI trial, or even the DAPA heart failure trial, and if you do a subgroup analysis, you will find that EGFR is the poor correlator of the outcome. With the normal EGFR also, the outcomes are bad. With the reduced EGFR also, the outcomes are fairly fine. So you need something more to that, and that is the place where probably urinary albumin, cystatin C also comes in the picture. And we need to understand, hence it is extremely pivotal when you're managing your patients of CKD, when you're monitoring your patients of CKD, it's not just eGFR that you're looking at. You need to also look at the urinary albumin creatinine ratio and its excretion. And earlier you intervene, better are the outcomes, as obvious is from this slide. So when we talk about prevention of development of, so whole cardio-renal vascular protection continuum, when you talk about it, the data from the DECLARE TB is outstanding. Nobody talks about DECLARE TB renal data. There is a lovely subgroup analysis which has been published and showed that there is a clear-cut reduction in the rate of decline of eGFR at the end of 6 months in the DECLARE TB trial. But what is most amazing in this DAPA heart failure trial is this, that major, and I'll tell you that DECLARE TB, not all were all high-risk atherosclerotic established patients. In fact, nearly 60% patients were non-atherosclerotic heart disease. So they looked at the primary prevention. The other SGLTs which published their trials initially technically gave us a signal, boss कि अगर मेरे को empagliflozin से benefit चाहिए तो मेरे को पहले heart attack होना पड़ेगा. I need to have one cardiovascular episode and then only the empagliflozin can benefit me. Even though the data has changed now, but during those days I am talking about. So same way DAPA heart failure also has told you that whether the patients are diabetic or not diabetic, the cardiovascular benefits and the renal benefits are absolutely phenomenal. And this is what already Kerkar sir has shown you. I'll just tell you about the kidney perspective. Where look at the robust reduction of 40% risk reduction in the patients developing end-stage renal disease, creatinine doubling time, need for the renal replacement therapy, renal or cardiovascular composite mortality. Now 30% or 40% may not hit you here, but what if I say that 1 in every 3 patients, the third patient you treated is benefited? Then you will realize the importance of the impact of this drug. And this was, sir has already shown this slide, where it has also stopped the development of the diabetes in the pre-diabetic or even non-diabetic population. And hence the recent guidelines which have come up. And before I talk about guidelines, let me give you a comparative analysis of DECLARE TB, DAPA heart failure and DAPA CKD. Amazing trials and amazing outcomes, where there is an overall protection irrespective of your status of diabetes, whether you are diabetic or not, whether you have got established heart disease or not, you have got established kidney disease or not. These drugs, they work and they benefit you in almost all, whether it is a primary composite outcome or the secondary composite outcome. More importantly, the latest 2019 European Renal Association and European Dialysis and Transplant Association has clearly recommended that these drugs need to be there on board even much before than probably you are doing. And even we all know that European Society of Cardiology has now probably given us a still, I would say, more broader perspective for use of these drugs. Like they told us that even when the patients are at the very high risk of atherosclerotic cardiovascular disease, or somebody has an established atherosclerotic cardiovascular disease, even SGLT2 can be actually initiated even before metformin, along with the therapeutic lifestyle interventions. I completely agree with the KDIGO guidelines as well. But lastly, I'll talk to you about this area. And let us do a small experiment. You have got all those small chip pads there with you. You are on the table. Just tear off 2 papers. Just tear off please 2 papers. Just tear them off. You have these papers, right? So just tear them off. 2 pages. And this is what I am going to tell you about what is the difference between the generic and the innovator stuff. So you have 2 papers with you, right? Just 2 papers. Show me 2 papers, right? Now the first, just make a small ball of it. Make it. Compress it and make a small ball of it. Right? Now here is a challenge. Make the second paper exactly identical to this. Make it. I need each and every crease, each and every fold, each and every size has to be exactly like this. Difficult it is, isn't it? So this is your innovator pill. This is your generic. Why? Because we need to understand that whenever there is an innovation, as Dr. Alka Deshpande was talking to me outside, that when you talk about the new inventions, when you talk about the new chemical entities coming into the market, when you have got 10,000 ideas, before even they take to animal trial, they are only 250. After animal trial, they are only 5 to 10. And till the time it reaches human use, hardly 1 or 2 out of 10,000 ideas, 10,000 new chemical entities they are. And it's a huge ongoing process of around 10-15 years. And look at the amount that they invest. It is around $800 million to $2 billion for one invention. How much our Mars mission costed? 70 million dollars. Perfect. So I can say that it is difficult to reach human body than the planet or outside planet. We need to understand the importance of this, and this is what exactly the difference between the generics and the innovator brands are. Always innovators will have pharmacoequivalence proved to be the same thing, but remember that pharmacoequivalence is not identical. Pharmacoequivalence means not everything about the drug. Pharmacoequivalence is not like bioequivalence. Pharmacoequivalence is not the same PKPD. Pharmacoequivalence is not the therapeutic equivalence. Because there is something called as chirality of the drugs. And I and Agam were in the team of position paper when we came out with the chirality in the medicine. There is a publication in our Journal of JAPI probably way back in 2017. I want you all guys to read about it. Because you need to understand that all these drugs are all three-dimensionals and they are all what we call it as the enantiomers. And there is a septal arrangements which is there, which is very, very difficult to copy. But it is this position of these molecules, these chirality molecules, it is extremely difficult to generate the same copies. At the same time, you need to understand that the process of manufacturing of generics actually also adds many impurities into the salt or the original innovator salt. Now these impurities are responsible for the change in the pharmacokinetics and pharmacodynamics, and there is a beautiful rosuvastatin study which has been published, which is a comparison between a generic and a innovator molecule, and they have shown that the benefit that rosuvastatin, and Kerkar sir would definitely agree to me that the benefit that rosuvastatin original brand has, the same protection could not be replicated, and this was a pivotal paper which got published in the American Journal of Pharmacology. So remember that similarly, whenever you get a chance to try and use the innovator molecules, because innovators are difficult to copy. And remember that similar looking does not mean identical. We all know the best examples are identical or twins or identical twins, we talk about them. So understand that dapagliflozin has given us entire perspective of covering not only management of sugar but also associated vascular burden. No matter it could be a cardiovascular burden or a renal burden, overall mortality, everything changes because of these drugs. Thank you very much. I'll stop here and we'll be very happy to have questions. Please, Amit and the team AstraZeneca, thank you very much for this beautiful opportunity. But I'll seek your permission, Amit. Just ask me quick one question and let me run.
Sure.
Okay.
Thank you so much, sir. I think without further ado, I would now request all panelists, and now we have the man himself, Professor Dr. Shashank Joshi with us. We have heard him virtually so far at 2 sessions this morning. I would request Dr. Joshi sir to please come on the panel, Dr. Tivaskar sir, Dr. Prafulla Kerkar to please join us. We should have a quick panel discussion. I know we are running late, but I would promise you we'll be out of here in a couple of minutes with a few questions to each one of these stalwarts. So Dr. Joshi sir, Dr. Tivaskar sir, Dr. Prafulla Kerkar, we welcome all of you onto the stage, please. We welcome Dr. Shashank Joshi sir. We welcome Dr. Tivaskar. And we welcome Dr. Prafulla Kerkar. Thank you, sir. So, after hearing all about the magic pill, we heard in the last 1 hour about how this particular drug is useful in the cardiorenal diabetic segment. I would begin by Dr. Joshi, because it's a question which sir has been into practice for years together now, has been a part of the guidelines of diabetes management also, and has been on national international forums. So sir, how has the evolution of diabetes and management of heart failure and CKD in diabetes been over the years in your practice? How has it evolved? Dr. Joshi sir, please.
So I think clearly heart failure has been an elephant in the room, predominantly discovered by pharmaceutical industry. As if heart failure never existed 20 years back or 30 years back. So that is my frank opinion. I know there are sponsors for this talk. I don't think they'll be very happy with my statement. But you know, I don't think that there was no heart failure, but it is discovered much more now. So how has diabetes management changed? We have better drugs and better outcomes. So formerly our outcomes were very glucose-centric. So we were only looking at managing fasting, post-lunch. A1C came in 20 years back. Then we didn't want hypoglycemia and weight gain. Again, pharmaceutically mediated concept, as if hypoglycemia did not exist 20 years back or 10 years back. But gliptins were there. So they had to replace secretagogues. And in the last 10 years, we saw advent of SGLT2 inhibitors and GLP-1 analogs. So obviously they had to have a new narrative. Now we have narratives in COVID like herd immunity. So like the narrative in diabetes today is cardio-renal outcomes. But it is backed by evidence. So I am not now sinister when I am talking. I think it is backed by very good high quality outcomes. And these outcomes will not be there in this decade. Because US FDA has taken away the mandate. Because this US FDA took out the mandate because of rosiglitazone in 2007-2008. They found a signal that rosiglitazone could cause heart attacks. Record trial showed it did not cause heart attacks. 2008 they passed a guidance that every molecule has to go through filter which is anti-diabetic through a cardiovascular outcome trial. Accidental positive effect was renal outcome. So DAPA is one such molecule which has undergone through this filter of both cardiovascular outcome and renal outcomes. So we have become outcome focused now. So we have started looking beyond glucose, beyond hypoglycemia and weight gain to cardio-renal outcomes. We are looking also at fatty liver. We are looking at quality of life, reducing pill burden, single tablet. And now we also have oral GLP-1 which is coming up. So I think it's going through a paradigm shift. The only challenge in India today is affordability, accessibility and universal application. So does everybody, every type 2 diabetic in India need an SGLT2 inhibitor? Well, I think if there is a cardiovascular component or a renal component, probably they need. So if you see ESC, ESD guidelines are very clear. There is a compelling need for high cardiovascular risk. Probably there is a need. So I think the outcomes have driven the modern recommendations backed up by science, and that is pretty robust. So though initially they started as an elephant in the room, they got backed up by good science and good evidence. That's all I would say.
Thank you, sir. I think that's a very good answer. From experience-driven to outcome-driven practice methodologies is what Professor Joshi has just elucidated. I will move on to Professor Praful Kerkar, sir. Do you use any risk scores in ASCVD heart failure for your patients to precisely target therapy, or you believe all type 2s with risk factors may develop this complication and put all of them on SGLT2 inhibitors?
Not really. Like Dr. Shashank just alluded to the fact that when you guys talk about legacy and we talk about the duration of diabetes, etc. So unless now diabetics, how they get treated is your business. But when it comes to purely treating heart failure as such, if there is any signal towards heart failure or just taking out of that empiric outcome trial, the first one, or declare kidney, once you are high risk to get cardiovascular disease, there is no question that you should look beyond sugar. And you should look to the fact that this is a guy, that stage A's and B's that I talked about. This is a guy who is going to, if at all, die subsequently. One major reason why he's going to die is heart failure. Correct? So we need to protect his heart. That is all important. And though the rosiglitazone business caused all that ruckus and therefore all these trials, CVOTs came along and now FDA has given up on that mandate, it's a different matter. But it makes sense to get after what is going to affect your survival. And I, for one, if the patient comes to me as a diabetic patient and I have got some other high-risk CVD in him, I for one am game to get onto both of these. Meaning, I don't myself prescribe diabetes, but I write back to Shashank, do you think this man is a candidate for SGLT2 or a GP1 receptor agonist? That's how it is.
Thank you, sir.
So that's as far as primary prevention is concerned. The secondary prevention we'll talk about it.
So well put, sir. Dr. Devaskar, you are a physician amongst physicians. We all are physicians here. And I think what the question topmost on every physician clinician mind here is the cost effectiveness. So how do you convince your patient when it comes to cost effectiveness and the overall efficacy of the SGLT2 molecules?
So, good question, Amit. And a good question, Amit. And it's a genuine challenge. I don't deny that, especially in the Indian subcontinent where patients pay from the pocket. We genuinely have a problem, but I have a little different take on it, honestly speaking. Number one is this, that I always try and convince my patient that yes, I do have a medicine which is little fairly expensive, but then it has got so much of long-term benefits that it may stop you from getting into the hospital for heart failure or for any coronary event or for terminal CKD or for something which may require for heart failure. And imagine, say suppose I have stopped somebody from getting, as Shashank has alluded to, that if you stop somebody from getting hospitalized for any reason, no matter cardiovascular event, nephro event, a stroke event or a hypoglycemia event, you almost saved the cost of the therapy for another 5, 6, 7 years. Right? So here we have a molecule which is so beautifully applicable. And now probably the innovators have also started realizing the fact, and especially when generic markets have started doing that. Innovators have also realized that now cost is the constraint, and people have already taken the steps forward to reduce down the cost. Now there are few multinationals which they still have got a crunch because they need to abide by the international rules and laws. But still they have taken a step forward to even give the benefit and cost one to our patients. So it's just like the same way the the insulin which was available, Glargine insulin. When the innovators were there, the costs were high, but then as the generics came into the market, even the innovators came down with their costs. So same way probably most of the people will do, and the benefit of the cost will be offered. So that cost challenge, that way also reduction of the cost will go away. Sure.
Okay, sir. So I think the take-home message from Dr. Devaskar's statement is that you make them aware of the larger picture, and then that's how you sort of save on the cost factor. Dr. Joshi has been a stalwart in his field. He's been a covidologist. He's been a person of international repute, but I know he's an endocrinologist and a diabetologist at heart. So if a type 2 comes to you, diabetic, and he starts developing microalbuminuria and LVH, then what do you say the role of SGLT2 at that point in time in your practice?
No-brainer. That's a clear no-brainer. I think we should start there. I don't see any compelling contraindication for this. And I think all guidelines are accepted. The cost was the only rate limiting step. In India, the cost is in complication, not in.
So this patient, Dr. Gerkar, comes to you. He's cured of his microalbuminuria. Stop. But become better. Would you stop the molecule SGLT2 inhibition? Would you still continue?
At least drawing an analogy. Okay, now we have, let's forget the albumin part. We are not really a nephrologist. We think that that is there. We nephrologists look so much at the albumin in the urine, like the diabetologist will look at their sugar levels. We distance away from that. And we have been taught, and the new guidelines very well tell us, that the ejection fraction, that's what a lot of people understand when heart failure is there. A change in the ejection fraction, somebody who has poor ejection fraction has improved. Like these new molecules can improve it by up to 10% within a year or so. Things like that. We've got data to that effect. These are mildly recovered, mildly reduced ejection fraction people, or they call them now as recovered ejection fraction. So they are HFrEF with recovered ejection fraction. That is, if you stop medicines in these patients, you actually push them down further again. And it's hard. If you get I showed you those graphs there. Once you get an exacerbation, then getting him back to the previous level, it does not happen. Every worsening heart failure event means that you've gone downhill in your natural history. So there's no question about. So taking that analogy, I don't think just because microalbuminuria has disappeared, you are the renal expert today, or Shashank can add that. You do not stop these molecules. Just like I don't for rejection fraction.
So, but are these, sir, these mid-range ejection fraction we talk about, are these all recovered HFrEF? or there is a separate
It's
entity?
difficult to say what every hand type of a thing, whether they were, like we've had patients. Recently I had a patient. We did a TAVR on her. TAVR as a aortic valve replacement done through this route. And she presented with heart failure, right? Okay, because it's sometimes rare to just get with a good ejection fraction type. Did a chakachak TAVR, gradients have come down, but even then, immediately post TAVR, 2 days later, she got bad heart failure, also got some complicated pneumonia because she was intubated and things like that. She came out of it all. Now today, as I saw her last week in the outpatient, her ejection fraction is down to 35%. And the valve is beautifully functioning. It's got and the kidneys are still around the borderline, 1.2, 1.3 PI, that way. So it is a spectrum. And in that entire spectrum, recently, just day before yesterday, we are moving away from dapagliflozin, but we are getting on to empagliflozin. Empagliflozin, DAPA trial is yet to come, deliver heart failure for preserved ejection fraction on the basis of Emperor preserved trial and Emperor reduced. They took everything together and they showed across the range of ejection fractions, SGLT2 inhibitors benefit the patient.
Point taken, sir. We've heard the clinicians. Incidentally, we have Dr. Anil Kukreja, who is the Vice President of the Medical Affairs AstraZeneca. Sir, I would want to ask you a question from the industry perspective. How do you see the future of DAPA in the times to come, and what is the pipeline in the future for Astra? If you could please take on the mic just behind you.
First of all, thanks for the opportunity to provide this question to us. Thanks for the opportunity to collaborate and partner here also. And I think I'm humbled with this opportunity speaking in front of the doyens, particularly Dr. Shashank Joshi, Dr. Praful Kerkar and Dr. Tivasta. Thanks Dr. Amit Saraf for this opportunity. So coming to DAPA, I think we heard a lot about it. Original research molecule is made accessible now. Coming to future, we will continue to follow up on these patients. We are doing DELIVER study as we just spoke. It is the event-driven trial. We are hopeful that DELIVER will read out in this year itself. We will have the data even on the preserved ejection fraction also. And we are quite hopeful on the results as well, based on the empagliflozin study which we have. We have a DAPA-MI study, which is a unique design where we are doing a randomized registry-controlled trial, where one arm will be in the registry, the other arm will be the actual prospective study which will be done. And this is a unique study design which will again evaluate and help us to understand whether it has a potential in the myocardial infarction patients also, when they are followed up, to further reduce the cardiovascular death as well as the cardiovascular hospitalization because of the heart failure. So this is about DAPA. About the AstraZeneca, I am sure everyone is familiar about it. Our collaboration with Oxford, we are really proud of bringing the vaccine for the whole world. Our local collaboration with Serum Institute of India, we brought the vaccine, and internally we celebrated the milestone of 2.5 billion doses of the vaccine supplied to more than 170 countries in the world, not only in India. And I think that is something which we are really proud of. We did not even stop there, because we know that there will be immunocompromised patients who may not be optimally benefited with vaccine. They may need a passive immunological support. So we had a cocktail of antibodies, monoclonal antibodies. Dr. Shashank actually guided us in one of our meetings, and he said that this has a potential. It is a monoclonal antibody cocktail which actually provides a passive immunological support for COVID-19 patients, particularly who are suffering from cancer, who are suffering from transplant, who are immunocompromised, and this can provide an additional immunological passive immunity support. Besides that, there are multiple, like of course AstraZeneca being innovator, we have more than 25 projects in the cardiovascular renal metabolic profile pipeline itself, and we have close to more than 100 projects in across the therapy areas. We will be discussing, I think one of the topic I saw in the agenda is severe eosinophilic asthma. We were able to bring benralizumab for the severe eosinophilic asthma. As far as CVRM pipeline is concerned, we have cotarutide, which is a dual agonist of GLP-1 as well as glucagon agonist, and this will help in addressing the all the fatty liver, the non-alcoholic steatohepatitis, type 2 diabetes, obesity. So it will address that kind of metabolic syndrome. We are uniquely looking at some of the unique mechanism of actions like endothelin receptor antagonist, then vascular endothelial growth factor agonist. We are looking at LOX1 monoclonal antibody. We are looking at relaxin as a pathway. We are looking at the podocyte health. And these are the multiple diverse pathways. I think a beautiful lecture by Dr. Tivaskar who explained what goes behind the research. So we are in the early and the late stage pipeline as far as all these mechanisms are concerned. And we are uniquely positioned to have these 25 projects progressing over the period of time. And I'm sure we will get more opportunities to present the scientific data to all of you the moment the data is available and read out in the international congresses.
Thank you so much, sir. I think that's a wonderful the pipeline. I think the last, before we end the panel, we are in the presence of the Brahma, Vishnu and Mahesh, the Trinity for almost this session. So before everybody disperses for lunch or other, in one bullet point from each one of you, one liner about DAPA. I would begin with Dr. Kerkar, Dr. Tivaskar and then last word by Dr. Joshi.
One-liner, you gave it magically.
Okay.
What is it? It's safe to use. I am talking about heart failure and DAPA diffusion. It is. I have, for one, tried to become a diabetologist thanks to DAPA diffusion. Okay? Because we understood that we should. I'm sorry. So I, for one, tried to become a diabetologist based on what you call DAPA diffusion. For us cardiologists who used to not look at the sugars, hand it over to the Shashanks and the Tivaskars. We have now become diabetologists thanks to dapagliflozin. It is extremely user-friendly drug. What we are worried about, hypoglycemia and all that ain't there. It has got remarkable benefits in terms of the outcomes that we are really looking at, and safe and easily tolerated. It is one dose. I give you the 10 commandments. If all those could be made into one long sentence, that's what it is.
But
It
sir,
fits
still,
the bill
but
for
still
all the 10.
But we want one small statement.
I would say it's an ideal anti-failure, heart failure treatment innovation.
Great. Dr. Tivaskar?
I am very unhappy because he's going to throw us out of job now. Agam is already, Snehal and me are going to be again out of job because it's like, Kerkar sir has started managing diabetes. But anyway, to me it's a new, I would say, sensation occurred. Really one very brilliant innovation which probably deserved all what it has happened. And one of the most important thing is this. Now we are going to better the whole thing, as we go ahead. Thank you.
And lastly, Professor Joshi, sir.
BMI about 20, SGLT2 inhibitors are very much there with metformin. They are giving metformin run for their money.
Thank you so much, sir. With that, we end the panel. I would